I got a request to do a video on bony thorax, so that's what I'm going to do today. So I'm in the classroom. It's an empty classroom. That's always a little bit odd, but I'm going to leave the background bright white like this so that we can use shadow to demonstrate what I need you to understand, especially in the obliques of the ribs. So we'll talk about um, the, the anatomy, the positioning for the bony thorax, the different exams that we're going to do for bony thorax. And we'll also take a look at some trauma, which is most commonly what you're going to see with bony thorax, is imaging for trauma. So the PowerPoints are, I edited them just a little bit. These are almost straight out of Merrill's. Most of the time I use heavily edited PowerPoints, but these aren't heavily edited. I cleaned them up a little bit and then added some images towards the end so that we can take a look at what happens whenever we have some severely broken ribs. So I'm going to post these into Canvas so that you'll have them, but they're pretty extensive and they include a lot of stuff that we otherwise probably wouldn't cover in class. So what I'm going to run through is basically what you're going to be held responsible for. Uh, you're going to want to read the PowerPoints as they are, just to make sure that you get all of the information, but I'm going to try to touch on everything that you need to know for the test. So I'm going to be skipping over a lot of the PowerPoints. So we're going to start with anatomy. So the bony thorax, let me get this guy out of the way. Bony thorax is formed by the sternum, the breastbone, and 12 pair of ribs. It's like what we talked about in thoracic viscera. And then you've got the 12 thoracic vertebrae. So even though we covered the thoracic vertebra the in the vertebral section and spines, it does form a portion of the thoracic anatomy. It's conical in shape. We talked about that in our thoracic viscera. So it's pointed at the top, broad at the bottom, narrow at the top, and it's shaped kind of like a cone. And then our lung is posteriorly is longer than our lung anteriorly, but also the bones are as well. So the inferior most portion would be the xiphoid process, which is this little thing right here on our skeleton. It is this little thing right there. So it's inferior most, and then our 12th rib is much lower than that posterior. So the functions of the bony thorax, of course, is protection of internal organs. So it supports the wall of pleura, varies in volume, all that. But primarily what we're concerned with is protection of the lungs, protection of the heart, protection of the great vessels. You've got the trachea and thorax, the trachea and the esophagus in there as well. So the sternum is again your breastbone, and that's positioned at midline, and it consists of three different portions. So we've got the manubrium, which is all the way at the top, and then we've got the body. And the body, I don't know if it's picking this up on camera or not, but you can see it on that picture over there. But the body is kind of serrated looking, kind of like a serrated knife or a steak knife. It's got these scallops where the ribs attach. So it's not just it's a flat bone, but it's not featureless on the sides. It has that scalloped appearance to it. So you've got the manubrium, and then you've got the body, and then you've got the xiphoid process. All the way up at the top up here where your soft tissue indents, right there is what we refer to as the jugular notch. And then right here, this is what we call the sternal angle. So the manubrium is superior, and then the body, and then the xiphoid process. So we just talked about all that. Xiphoid process lies over T10. So, it makes for a decent positioning landmark for chest x-rays, AP chest x-rays. You got to be above T10. You got to be at T7 for positioning of that. All right. It's a lot of information. Oops, going the wrong direction. So your ribs, you have 12 of them, and they are numbered from top to bottom, 1 through 12. And again, like what we talked about in thoracic viscera, you have true ribs, and then you have false ribs, and then you have floating ribs. So true rib is anything that has a direct connection to the sternum, including the manubrium. So we're including that in just when I mentioned the sternum, I'm talking about the whole structure there. So our first, second, third, fourth, fifth rib have direct connection, sixth, seventh have direct connection. And then you notice once we get to the eighth rib has to connect to the costal cartilage. You can see the difference in the coloration on each, one of these sections. You've got the rib here, and then this more translucent looking thing is supposed to be representative of cartilage. So you've got direct connection to the sternum all the way down, and then eventually down here, you've got indirect connection. So this connects to the costal cartilage of this rib, and then so on and so forth, until you get down to numbers 11 and 12, and then those are what we refer to as our floating ribs, and they have no anterior connection at all. So your rib itself, you've got an axillary portion, then you've got a posterior portion. That's what comes all the way back to the vertebra. Your axillary portion is kind of the main curvature, and then your anterior portion only comes around so far before it ends, and you don't have anterior ribs all the way up to the sternum. You've got direct connection with the costal cartilage. So they're long, narrow, and very steeply curved. And I know earlier in the semester we talked about curved bones and where you're going to have, a curved bone. If you have a fracture in one place, you're going to always have a fracture in a second place. And the ribs are going to kind of break that general rule. And I think it's largely because the connection anteriorly, you get some flexibility there. It's not held as firmly in place as like what you would see with your anterior pelvic bones. With your ribs, in a lot of cases, you'll see a fracture in a single place on a rib. So you're not going to have multiple, you can have, but you're not always going to have multiple fractures on a single rib. Vary in length. They increase in length. They're pretty short at the top. Around the middle, they get pretty broad, and then they decrease again all the way at the bottom. We just talked about all the different types of ribs. So you got true ribs 1 through 7, 8 through 12 are false ribs, with 11 and 12 being floating ribs. So the portions of the rib, what we've got is a head, a neck, a tubercle, and a body. So the body makes up the most of it. So the head is where we articulate with the vertebra. So we got the thoracic vertebra here. Head articulates there. We've got two facets. We've got a facet that articulates with the body, but we've also got another one that articulates with the transverse process. So that's the head. Just below the head, we've got the neck, and then the tubercle, and then we've got the rest of the rib, which is the body. So where we've got those articulations are your costovertebral joint spaces. All right, so respiratory movement, whenever we breathe, our lungs will expand in really at least 2 dimensions, maybe 3 dimensions, but they, whenever you inhale, what happens is your diaphragm drops, and that creates a vacuum, and you draw air in. At the same time, your ribs lift and separate just a little bit to exaggerate that, to draw in more air. Now, that's going to be an important thing here in a bit whenever we talk about rib fractures and how the structure of the rib and the integrity of the rib cage itself plays a part in patient outcomes whenever they have multiple broken ribs. That's what we refer to as a flail chest. So the diaphragm moves about 1.5 inches between deep inspiration and expiration, more in some patients, less in others. If you have a patient who has like a swimmer's or a runner's build, you're going to have more. If you have a hypersthenic patient, it's going to potentially be less than that. So you have to consider that in your positioning, your ribs as the patient inhales. Your thoracic cavity expands in a lot of different ways. Just like on chest X-ray, you have to consider the expansion of the thoracic cavity whenever you're placing your image receptor, your collimated field. Procedural guidelines, just like everything else, get artifacts off of patients, practice radiation protection, good patient instructions, make sure you use your markers. Your SID, you can use 40 inches on most patients. If you've got a very broad patient, you may back up to 72 inches. So we talked about in physics, maybe those with sophomore students, at lower SIDs, your beam diverges more than what it does at 72 inches. So as we increase our SID, we get less beam divergence. So if you have a patient that you're concerned with being too broad for your image receptor, you might want to use 72 inches instead of 40 inches. You use more of a perpendicular central ray as opposed to a divergent central ray. Most of the time you can get by with 40 inches. So make sure that you get the artifacts off the patient, necklaces, any kind of clothing artifacts. If the patient has some sort of telemetry on, then you're just going to have to deal with that. If it's an ER patient and they've got EKG leads on, you're just going to have to deal with that. But anything that can come off the patient, you need to get off. Get off the patient. Sometimes if the patient's on a backboard and you're shooting a true trauma patient, you're going to see the artifacted backboard on your image. You just can't get around it. So if you can get it out from under the patient, if you can get it off of the patient, then it needs to go away. So ambulatory patients with rib injuries, true rib injuries, there's going to be positional pain, just like in the shoulder. So I recommend that you move the patient as little as possible. So if the patient comes in laying down, if you can use a slider board to get them from the bed onto the x-ray table, I recommend doing that so the patient doesn't have to move around a whole lot. If the patient is in a wheelchair, I recommend that you shoot the patient upright. Even if they're in the wheelchair, just go ahead and complete them in the wheelchair. Sometimes you can take the backs and the sides off the wheelchair, and you can leave them sitting in the wheelchair. Sometimes you may have to put the image receptor behind the patient in the wheelchair. Move them as little as possible. It's painful to move. It's painful to breathe. It's just better to move the patient as little as possible. So certainly in non-ambulatory patients, you're going to shoot them with them laying down. Ambulatory patients, you've got your options. If they're already laying down, shoot them laying down. If they're upright, shoot them upright. And trauma patients, you just got to take what you can get. And most of the time, they're going to be supine as they can be. So your collimated field size is going to be determined by the anatomy that you're shooting. So what your order tells you that the doctor needs to see. So sternum small bone, 10 by 12 lengthwise at the absolute most. You can collimate in less than that, side to side. Lengthwise, I really wouldn't recommend it, but you collimate down to instead of 10-12, something like 7 by 12 or something like that. If we're looking for sternoclavicular articulation, sternoclavicular joints, we collimate down to a smaller area than that. So your sternoclavicular joints are these things right here. That is the only bony union between the upper extremity and the trunk is the sternoclavicular joint. So we've got a couple of different views for that. Full disclosure, never shot one in my entire career. I don't even know that I know somebody who's shot any sternoclavicular joints. Still testable, so we have to cover it. And then the ribs were used 14 by 17, and that might be crosswise for your hypersthenic patients. Your 17 dimension may be going across the patient, and in your asthenic or hyposthenic patients, it may be going the length of the patient. Excuse me. So we talked about SID already. For ribs, for sternum though, we can do a couple of different things. All right, so the sternum, everything that we've talked about this semester as far as imaging and maintaining a sharp image, we're going to kind of throw out the window for sternum. So we're going to utilize a lower SID at 30 inches instead of 40 inches for sternum. And the reason for that is because the sternum is very, very difficult to image. It's a relatively thin bone. Like on this skeleton, I'd say that it's three quarters of an inch thick. So it's a relatively thin bone, and we've got a lot of stuff to get out of the way in order to visualize it. So even in best case scenarios, we're going to have soft tissue, a tremendous amount of soft tissue on it. Patient's back, patient's, their anterior chest wall may have the heart on it, which we prefer to have the heart on it. We're going to have lungs on it, and then we've got the ribs going across it. So it's very difficult to image. So what we're going to do is we're going to shoot. I'm getting a little bit ahead of myself here, but if we put the sternum closest to the image receptor, and you can get the sternum pretty close to the image receptor, it's fairly shallow bone on most patients, so you can get it pretty close to the image receptor. Now, what that does is it puts the ribs further away from the image receptor, so you're naturally going to have a loss of sharpness and recorded detail of the ribs, which is what you want. So what you know about SID, OID, and sharpness or recorded detail is that if we increase our OID, we lose sharpness or recorded detail. If we decrease our SID, we're going to lose sharpness or recorded detail. So we're going to shoot the patient PA not to lose, that'll give us a sharper image of the sternum because we're closer to the image receptor, but we're going to lose some sharpness or recorded detail of the ribs. And then we're going to drop our SID down to 30 inches instead of shooting at 40 inches. That's not to lose sharpness or recorded detail of the sternum, but rather to further lose sharpness or recorded detail of the ribs, those posterior ribs. So your SID is going to be 30 inches. It's going to be a PA projection, and we'll get to that here in a bit. For your lateral sternum, though, you can back it up to 72 inches. You don't have all that stuff on top of it. You're not trying to lose the sharpness or recorded detail on the ribs. You just, you're shooting kind of like a lateral chest x-ray, collimated down just at the sternum itself. And then ribs, you can go with 40 inches, 72 inches. We already talked about that. Markers, use them. Radiation protection, collimation is your most common. Remember your shielding, that is kind of up in the air at this point. Whether or not you use shielding would be according to your clinical site's recommendations or requirements on using shielding. And then certainly you want to optimize your technical factors. So you want to have very clear instructions for the patient. Some of them are going to be breathing. Some of them are going to be holding their breath at the end of inspiration. Some will be holding their breath at the end of expiration. So be very clear with your patient, with your expectations for their breathing and their position. So the essential projections for the sternum, we're going to do a PA oblique. We just talked about that a minute ago. We're going to shoot PA projection, put the sternum as close to the image receptor as possible, 30-inch SID, and then we're going to do an upright lateral. We're going to do a lateral of some sort. It could be upright. It could be cross table with the patient laying down. It could be shooting into the table with the patient laying on their side. So they're going to be recumbent in some position. Personally, it's easier for me if you just shoot it at a shoot across table. All right, so what we're going to do for the PA oblique, and it's going to be a RAO position. So you got to think about your anatomy. What you've got in the thoracic cavity, of course, you've got your lungs, and you've got the ribs, and then you've got the heart. And the biggest portion of the heart's on the patient's left-hand side. So what we're going to do is we're going to actually use the density of the heart and project it onto the sternum to increase the density of the sternum. So what we're going to shoot is RAO. We're going to oblique the patient only about 15 degrees. And we're going to shoot just to the lateral side, to the left-hand side of the spine. Okay, so in that obliquity, what it's going to do is it's going to take the heart, which is right here, left ventricle is here, and as we oblique the patient up, what that's going to do is it's going to put the sternum right up under the shadow of the heart. I don't know how well you can see that, but as we oblique the patient up, it's going to put the heart over the top of the sternum, increases the density of the sternum. So at the same time as 15-20 degree RAO position, make sure that the patient, secures himself into position, put the top of the image receptor about 1.5 inches above the jugular notch. So again, that's a soft tissue indentation. So you oblique the patient up, get them in a stable position, right? And then what we're going to do is we're going to do a breathing technique. If your machine will allow you to come into 30 inches instead of 40 inches, some of your machines will just lock in at the detent and they won't allow you to reduce your distance. So come in 30 inches and then you're going to shoot a breathing technique. All right, so where we've told you all semester, make sure the patient's still and use as low of an OID and as large of a SID as possible. We're going to throw 2 of those out of the window. We're going to have the patient move, so they're going to breathe, and we're going to have the SID at 30 inches instead of 40 or 72. Okay. So it becomes difficult to phototime a good sternum because your presets probably are not going to give you a good breathing technique. So you may need 2-3 seconds in order to get a good breathing technique. And your presets on your control panel are probably going to come up with maybe 200 MA or something like that, which means the patient's going to have to be pretty big in order to get that kind of mass. So what you might have to do in order to accomplish a breathing technique, if you're phototiming, is override the MA. So drop the MA as low as it will go. Still activate that center cell. So you may have to just completely go without the presets. You may have to set the center cell, and you might have to manually lower your MA to as low as it will possibly go. Set the center cell. Use a lower KBP, maybe a 70 KBP. And I know that seems like it's awfully low, but you're trying to get a breathing technique for the lungs, so it's going to be difficult to do. So 15-20 degree right anterior oblique, 30-inch SID, breathing technique, center cell, lower KBP, low MA should give you extended exposure time. You might want to go ahead and use your +1 or +2 densities, or the icon that's on your control panel for hypersthenic patients, or at least sthenic patients, a larger patients, in order to make sure that you get adequate exposure. So these are very difficult to see on an image. So again, just real briefly, 30-inch SID, the patient's going to be rotated 15-20 degrees in the RAO position. Just have the patient brace themselves with their arm like so, and a bent knee just to hold themselves in place if you're shooting spine. If the patient's upright, you might have them hold on to the wall bucky. Top of the image receptor about 1.5 inches above the jugular notch, and then your central ray is going to be about 1 inch lateral to the mid-sagittal plane, or to the lateral side of the spine on the elevated side at the level of T7. So you should be pretty familiar with T7 by now. We've used that for T-spines, chest x-rays, and now sternum as well. So then what we get is this in our image, and what you see here is the manubrium. So that jugular notch right there, manubrium, sternal angle, and then we've got the sternum proper, the body of the sternum with those scalloped edges. This is about as good a sternum as you're going to see. Be aware that this is a very tough image to get well on the first try. So even a lot of your seasoned technologists are going to struggle with this. So you as a student, you're going to have a hard time with this as well. Also, you're likely not going to completely comp out on sternums. without doing some sort of simulation. Chances of you seeing 3 separate sternums really pretty slim. So your lateral, again, you're going to back up 72 inches if you can, as just reduced magnification. Patient could be upright, or they can be dorsal decubitus, meaning laying on their back so that you can shoot them cross table, or you can roll them up on their side. I would really recommend the upright or the dorsal decubitus. Putting them on their side, you introduce a lot of soft tissue that is hard to get out of the way. So with them laying on their side, you know, they can't really lay with their arms down to their side completely, because to do so, they would lay on their arm that's closest to the image receptor, right? If they put their arms out in front of them, now they've got all that soft tissue. If they put it over the top of their head, or they put their arms up over their head, then also that soft tissue has a tendency to kind of gather. So really, cross table lateral, probably your better answer if the patient can't stand up. But if the patient can't stand up, you can get 72 inches and you can shoot lateral left. All right, so center of the sternum to the middle of the grid. See, this is what I'm talking about here. You've got a lot of soft tissue there that you're just not going to get out of the way. But if you have a patient stand up, if you remember how I told you to position for a lateral C-spine, have a patient join their hands together behind their back and then reach for the floor, and it kind of pushes their sternum out so that you get rid of some of the soft tissue. And then this is what you're going to see. So this, again, is about as good a lateral sternum as you're going to find. If you have a patient who has any kind of size at all, you know, any kind of soft tissue, be it because they are in the gym a lot and they've got big pecs, or maybe it's a patient with big breasts, it's going to be difficult to see the sternum this well. So just whether it's AP or lateral sternum is just not easy to get a good image of. So for the sternoclavicular joints, our essential projections are just PA and PA oblique. And anytime we're doing sternoclavicular joints, we're going to do bilateral. So we're going to do left and right. And with PA projection, what we're going to do is we're going to position the patient prone or facing the image receptor if the patient is upright. And what we're going to do is, again, position the patient prone with their arms down to their side, and then have the patient look in one direction or the other. Most patients are not going to be flexible enough to turn their head without turning their body just a little bit. So as the patient looks to their right-hand side, what's going to happen is their body's going to rotate just a little bit. It's not enough to call it oblique, but it does turn the body just slightly. But what's going to happen with that is, as I look to my right-hand side, my spine is going to go that way, and my sternoclavicular joints are going to go that way just a little bit. So they're going to be bilateral, so you're going to position the patient prone, have them look to the right, and then have them and make your exposure, and your positioning is going to be right at the jugular notch. Have them look to the right, make an exposure. Have them look to the left, make an exposure. And again, what's going to happen is that as I look in one direction, what's going to happen is the spine's going to move in the opposite direction. So whatever side I'm looking towards, I'm going to see that sternoclavicular joint. The body's going to oblique just slightly. So what I'm going to see is, on the elevated side, I'm going to see that sternoclavicular joint. Okay, so bilateral. Look to the left, make an exposure. Look to the right, make an exposure. And what we should see is this. Now, what you're seeing here, if you remember back to your chest positioning, what we have and how we identify rotation from PA projection is looking at where it looks like the clavicles intersect the spine. And of course, it doesn't, because the spine's back here and the clavicles are up here. But it looks like that on a two-dimensional image. So what you see then is, you should be able to see the difference in the gap in between the spine and the clavicle on both of these. So the patient was looking that direction for this one. and the patient was looking this direction for that one. So what we're seeing then is sternoclavicular joints. You can see it on the downside on that one. You can see it on both sides on both of those. But you're going to shoot both of them, look in one direction, look in the opposite direction. The other one truly is an oblique. Let me advance the slide. And with the oblique, our positioning of our central ray is really going to be pretty much the same, except for, as far as vertical positioning of the central ray to the jugular notch. But what we're going to do is we're going to oblique the patient up 10 to 15 degrees. And now what's going to happen is I'm going to oblique the patient enough. So here's sternoclavicular joint is right here. So as I oblique the patient up enough, my spine goes that way far enough, and my sternoclavicular joint goes that way far enough at 10 to 15 degrees that instead of seeing the side that's elevated, what I'm going to see is the side closest to the image receptor. So the PA projection is going to show you the side up, the side that's elevated. The PA oblique is going to show you the side that's closest to the image receptor, the side down. Okay, so 15, 20 degrees. Again, LAO, RAO, 10 to 15 degrees. And what that should do then is put the sternoclavicular joint that's closest to the image receptor, out from under the spine. So that would be right here. If we drew that line straight up, then it would be just slightly out from underneath the spine. So again, it looks like that. There's the spine, there's the sternum, and there's the clavicle, so we can see the sternoclavicular joint there. So it's very likely that you would shoot ribs at some point. Remember, in your trauma situation, your chest x-ray is always going to come first, and your chest x-ray is going to double as rib x-rays. The reason for that is going to be more apparent here in a bit, but it doesn't really matter what's going on with the patient. If they got a compound fracture of the femur, that's great gee whiz stuff, and it needs to be addressed, it needs to be fixed. But if a patient has maybe bilateral pneumothorax, both lungs are collapsed, atelectasis on both sides, the patient very well may suffocate before you can get into surgery to fix that hip or that femur. So the chest x-ray is very important to visualize, and very common to have rib fractures go along with a trauma situation. So what we're going to do with ribs is we're going to do PA or AP. You don't have to do both, but you're going to have to select, depending on where the patient's pain or maybe the trauma appears to be, the bruising, the contusion, where it might be. So if you're looking at anterior ribs, you're going to shoot PA projection to put the ribs closer to the image receptor. If you're looking at posterior ribs, you're going to shoot AP projection. So PA for anterior ribs, posterior ribs, you're going to shoot AP. Did I say that right? PA for anterior ribs, AP for posterior ribs. And then the same thing with obliques. You're not going to shoot AP and PA obliques. You're going to shoot for whichever portion of the rib is injured. So what we're going to see with PA and AP is anterior ribs, and I'll put that in air quotes because you only have so much anterior rib, but you're going to see posterior ribs as well. So the AP and the frontal projections are going to give you the anterior posterior ribs, and then the oblique is going to show you probably where most of your rib fractures are going to occur. Side impact collisions, they tend to take out the ribs. So that's going to show you the axillary portion. So with your PA ribs, again, you can shoot it with the patient upright or laying down. Whatever position the patient comes to you in, that's the position you want to shoot. So body position wise, either up or laying down. If you got a patient that's got potential anterior rib fractures, I really recommend you try and get them upright. And that's going to be according to the patient's ability. If a patient starts to stand up and they get faint, then you're going to have to sit them down pretty quickly. And even if they have anterior rib issues, then you may have to shoot AP instead of PA. It's just not going to be a good position to put the patient in prone if they potentially got rib fractures. It's just not going to not going to work real well. So if at all possible, we want to get them upright because we can have complicating issues with rib fractures. What's going on underneath the rib fracture is much more important than visualizing whether or not the patient has broken rib. Is the lung still inflated? That's one. If the lung is still inflated, but let's say mostly inflated, you don't see a pneumothorax, but you see blunted costophrenic angles, that may be a good indication the patient has a hemothorax. So a hemothorax is blood where you would have a pleural effusion. So it's blood outside the lung, but inside the thoracic cavity. So that can happen. A word you just kind of need to file away because you may hear it or see it eventually is hydrothorax. So a hydrothorax is kind of non-specific. And because of that, people don't use it very much anymore. You just don't see it a whole lot used, but you might see it eventually on a test question. Hydrothorax just means some sort of fluid, like a pleural effusion. So it could be a hemothorax, could be a pleural effusion. Hydrothorax is just kind of catch-all for all of that. Pleural effusion or a hemothorax is more specific. So anyway, I want to shoot the patient upright if we can so that we can see those air fluid levels. Also, it's going to be tough to see harder to see a pneumothorax with the patient laying down. Not as hard as seeing pleural effusion, but it could potentially be difficult. So positioning here should sound very familiar. So top of the image receptor, 1.5 inches above the upper portion of the shoulders, just like chest x-ray. Put the hands on the hips, rotate the shoulders out of the way as much as you can. Get the arms, soft tissue of the arms out of the way. Positioning for the upper ribs on PA rib x-ray is just like a PA chest x-ray. Okay, so it should look like this. Now the difference is this. All right, so whenever we're taking ribs, we want to visualize all of the ribs. The problem is on a PA chest x-ray, what we're going to see is we're going to see 10 posterior ribs. So, and most of the time it's just going to be partial. The problem with rib x-rays is that the patient can't breathe in as deeply as they would like to, and what you would like for them to for a chest x-ray. So you might not get 10 posterior ribs. In addition to that, the diaphragms may be going across a rib. You might not see the entire rib. So in order to make sure that we see the entire rib, what we're going to, and see it clearly, is we're going to shoot two different APs. We're going to shoot one for all the ribs above the diaphragm, and then one for all the ribs below the diaphragm. So for the ribs above the diaphragm, your breathing instructions are going to be just like for a PA chest x-ray, and that is to take in a deep breath and hold it. Have them take in two if you can get them to. Take in a big deep breath, hold all the way up, take in another big deep breath and hold it, and that's going to depress the diaphragm as low as it can so that you can get as many ribs above as possible. Your second one, though, is going to catch those bottom ones. So what you want to do then is to move your centering point. You're going to lower your centering point, and this time you're going to have the patient take in a big deep breath, blow it all the way out, and what that's going to do is going to elevate the diaphragm. So you're going to have some overlap. The ribs, the diaphragm may be going across. You should be able to visualize the entire thing between those two views. It's kind of a composite view, so that you get one of the upper and then one of the lower. So inhalation for the upper, exhalation for the lower, so that you get that overlap. This guy's a little unstable. Okay, so evaluation criteria for the above diaphragm, at least 1 through 7 in its entirety, and then the rest on the lower. If the patient's laying down, AP ribs, just make sure you get the arms out of the way. You put the hands behind the patient's head and put their elbows up like that so that it rotates those scapula out of the way in as much as it can. Top of the image receptor, again, 1.5 inches above the top of the shoulders.